Welcome back. In this last of the 1.0 series, we're going to learn a systematic method for interpreting EKGs. So behold the normal 12-lead EKG. I think it's a good idea when you're sitting down for each session to study EKGs that you spend a few minutes just looking at a normal EKG. And don't just stare at it randomly. Just excursively go through and say, what are the inferior leads, 2, 3, and AVF? How should they look based on the leads that represent them? How should 1 and AVL look, V1 and V2? And what are the differences between V1 and V6 in terms of how they represent the heart's electrical activity? And look at AVR. It's so weird. And then look down at the rhythm strip and see if you can identify all of the waves, intervals, and components of the EKG. So the method for interpretation, I use the mnemonic checklist raised right. And the reason I harp on this is because we want to be efficient, but also be thorough in our approach to electrocardiography. And so the R in raised right is going to represent rate and rhythm. The first thing we're going to do is determine the rate. And frequently this is going to be given to us by the monitor or by the machine. And we just want to make sure and verify that. After all, if the patient's heart rate is 13 or 213, then whatever their axis is probably not that material to the patient's condition. Next in the triage order of things is going to be rhythm. Rhythm also is super important. If a patient's got an idioventricular escape rhythm, that's going to be much more important than, again, determining the patient's axis or whatever. So those two come first. And then next we have access. If the patient's stable enough to move on to access, we want to determine that. We're going to use a very practical method for assessing for the heart's electrical axis and then try to sort out what can be significant in terms of abnormalities of heart axis. Next are going to be a big category, which is going to include both intervals and increased chamber size. Now, intervals is going to include the PR, the QRS, and the QT intervals. So there's a lot to unpack in that side. Also, in the under the rubric of increased chamber size, we're going to be looking for the indicators of ventricular hypertrophy and atrial enlargement. Next is the all-important ST segment and T wave analysis, as well as other indicators of infarction. Now, you might be asking yourself, if it's so important to properly assess the ST segments and look for infarction, why is it buried down on number 4 in your list? Well, if we think back to the whole quick look method, after you've had some experience reading EKGs, STEMIs and ST segment abnormalities are going to kind of jump out at you on your quick look. And so we want to be able to recognize those abnormalities, but then move on to a more systematic interpretation of the EKG. Next is going to be EKG changes associated with electrolytes and environmental disorders. And then lastly, devices and drugs. So that's the raised portion of our mnemonic, and on the right you can see the word right. In the right-hand column you can see each of these rights are going to be representative of things that need to be in place to make sure that your EKG is a sound medical legal document. For example, the patient's correct name and date of birth needs to be on every EKG. It's not usually the case that the wrong name gets on an EKG so much as there is no name. In the heat of a STEMI or a heart attack, they will print off the EKG with no patient information on it, and somebody forgets to slap a patient ID sticker on there, and then you've got this nameless EKG sloshing around in no man's land. That's not the way to do that. You want to make sure that every time somebody hands you an EKG, if you put an interpretation on there, you need to make sure and put the patient's name and date of birth if they haven't done so already. Also, the correct date and time at which you interpret the EKG. If you do an EKG at 8 o'clock in the morning and another one at 8:30, you want to be able to compare the two and assess for any differences. Next is going to be the right hookup. You want to check every EKG. In a moment, we'll look at what can happen with an incorrect hookup. And then we need to check the speed. Make sure that somebody didn't mess around with the recording speed and that we're recording at 25 millimeters per second. The right comparison. If we do an EKG and we see some T-wave inversions and those have been present in that patient since they were 23 and they're now 46, that may not be a significant finding. If, however, we have a diabetic female, 60 years old, and she's complaining of fatigue and shortness of breath and has a new left bundle branch block compared to her previous EKG, that certainly could be significant. So as we have suggested, EKGs are really important medical legal documents. They can give us lots of information from a very cheap, easy to perform and non-invasive test, but there are lots of ways to screw up an EKG, either in the way we do the test or in the way we interpret it or in the way that we make medical decisions based upon a particular tracing. So with that in mind, let's go through the top 10 ways to screw up an EKG. And number 10 is incorrectly hooking up the EKG. Now again, this is normally done by nursing or ancillary staff, but it is your job to make sure that the EKG is properly hooked up and properly recorded. If you look at lead 1, we can see that lead 1 strangely appears to be all upside down. We know that in lead 1 we should see a P wave QRS complex and a T wave that are right side up, and yet they are upside down, negatively deflected. If we move over to AVR, the weird reversal lead, we know that in a normal patient this lead should be upside down. We should have a P wave QRS and T wave that are upside down, and yet it's right side up. That, of course, is because we have limb lead reversal. We've just swapped the right and left limb leads, and that, of course, has produced this weird finding. So just to drive the point home, on the left you can see that in leads 1 and AVR, their amplitude or deflection has been reversed as a result of putting the electrodes on wrong, and then after corrected they go right back to normal. You know, it's interesting, but sometimes a computer, if you hook up the EKG wrong, it will produce an interpretation like ectopic atrial arrhythmia or something like that, and it's simply because you've got the leads hooked up the wrong way. Next up is number 9, which is the wrong patient ID or no patient ID on an EKG, which we've already talked about. And then next is going to be accepting a poor quality EKG. Now, we have mentioned how the ancillary staff normally make these or hook up the tracings. If you see in the bottom line here, we can see something that looks like a sinus bradycardia, looks like a P wave of some sort, some kind of QRS complex, and some kind of inverted T wave. But it's hard to make out at all what's going on here with the ST segments because of this wandering baseline. This is not an acceptable EKG to be putting into a patient's chart. If somebody hands you an EKG like this, you need to see, I'm sorry, this is not going to work. We need to repeat it. Also, we've got some artifact in the baseline here, which essentially makes the EKG uninterpretable like the previous one. This one needs to have the leads cleaned or get away from some source of electronics, but something needs to be done to give that baseline a haircut. Next up on ways to screw up an EKG, failure to clinically correlate EKG with patient presentation. So on the left-hand side, you can see in V2 and V3, here and here we have these inverted T waves. So this is normal in pediatric patients, and it has to do with how their electrical axis changes over time with development. Sometimes this pattern will persist into a patient's 30s. With that in mind, it's important to recognize that in these populations, T-wave inversions is probably not a big deal and probably represents a normal variant. However, deep anterior T-wave inversion in the elderly population with risk of cardiac risk factors is a big deal. Next up is going to be confusing artifact with an EKG abnormality. You can see here in lead 1, if you know anything about arrhythmia interpretation, this is going to look strangely like ventricular tachycardia. At this point, we would assess the patient, and if the patient is alert and oriented and their vital signs are stable, we would probably notice that in lead 3, there is a normal complex, and what's happening here is some muscle tremor artifact. So just make sure that anytime you see something weird on the EKG, you look for a clinical or some other kind of artifactual correlation to help explain it. Next up is failure to get expert or peer consultation when needed. Early on, I recommend that you have somebody else look at your EKGs with you that has some experience in the matter. Also, if you have a high-risk situation to where the EKG, you think it's abnormal, or you thought it was going to be abnormal and it wasn't, something's not adding up, or you just have to have some additional input before you make a clinical decision, you should feel free to consult cardiology, particularly when the stakes are high. Next up is relying on computer interpretation alone. If you look at this 12-lead EKG, this was taken and the computer has indicated that it suspects a heart attack, acute MI suspected. Now, this patient actually has a very benign condition called early repolarization, but knowing about the limitations of computers, they can alert you to potential problems, and they tend to be very sensitive but not adequately specific, and so beware of the computer interpretation. Next is relying on quick look interpretation alone. We've said that with time and experience, you're going to be able to just look at an EKG and identify certain abnormalities like ST elevation MIs, and that's going to be a function of ongoing practice. However, experienced clinicians have a tendency to over-rely on the quick look interpretation. More than a few times I've seen the attending physician be given an EKG in the ER, and he looks at it for 3 seconds and says, "I'm unimpressed," and then lays it down. What we want to do is do the quick look, but then go back and with our checklist, make sure that we're hitting all of the important parts so that we don't miss a subtle but significant finding. The number 2 way to screw up an EKG is failure to develop a differential diagnosis for EKG findings. Widened QRS complex can be associated with an underlying bundle branch block that's been there for years, or it can be hyperkalemia, or it can be ventricular arrhythmia, or tricyclic antidepressant overdose. So you have to begin to start taking these EKG findings and then correlating with them with the other patient data. Another example is going to be sinus tachycardia. You have a patient that's 38 years old who's complaining of shortness of breath, and her heart rate is 122. That is not normal. It could mean that she has pain. It could be that she's anxious, or that she smoked crack before coming to the ER, or that she's got a blood clot in her lung, or that she's septic with urinary tract infection. But tachycardia always means something, and so you have to develop a differential diagnosis to consider what might be generating the elevated heart rate. And last but not least is the top number 1 way to screw up EKGs is to not acquire adequate training in basic electrocardiography. If you work through the videos and do the readings and practice EKGs, you'll be well on your way to acquiring a firm foundation in reading EKGs. Next up is going to be the 2.0 series, in which we'll learn the methods for determining the heart rate on EKGs.